joining us. We have got some time now today to be talking about the topic of social and environmental factors. And we have a set of kind of guiding questions for us to work through. The first question is thinking about this topic of social and environmental factors. I guess I'm just, maybe we can start out by thinking about what are some of the major thoughts that come to mind related to that topic that feels like we have, actually, sorry, let me start with I think that I'm, with the first question. I think they want us to think about, is there anything big missing? There are four major topics that we talked about that were brought up yesterday. Social and environmental factors, technology, optimizing value, and infrastructure. And are there additional big topics or key trends that we have not considered and that we need to be thinking about?
Yes, ma'am. This is Patrick. When you think about the social determinants of health, and it's normally 12, but it's condensed down to 5, you can also include things like education, which around that would include early childhood education and development, language and literacy, and things like that. You can also look at the social and community context, where you can include discrimination, incarceration, social cohesiveness. If you look at some of the systemic problems with environmental racism, where normally people of color live in areas that are normally polluted or maybe built on toxic wastelands, stuff like that. And sometimes a lot of people don't consider those things to impact a person's overall health and well-being, but they surely play a big part. So when Dr. Hardiman mentioned yesterday about redlining, you know, all of those factors need to be taken into consideration also when you're talking about that.
Thank you for sharing that.
So just to build on what Patrick said, I think first of all, we have in the past, and I mentioned this yesterday, we've focused on disparities, but what we're really looking at is moving the frame to a frame about justice and delivering just health to everyone. And I think that if we start from the big goal rather than these smaller goals that are not just, not the disparities goal, but the justice goal. What does a just health care system look like, and what does just health look like in access to health? I think that's a really, really important place to start. The other thing I just lost my train of thought. The other thing I was thinking about after Patrick talked about it is that when we consider the social determinants of health, we're also, I know what I was going to say, sorry. Patrick talked about redlining and Rachel Hardiman talking about redlining, but when people outside think about redlining, they think about it as a redlining in terms of housing, but it has led to redlining in terms of every aspect of life. So there is redlining of health, not just redlining of housing. So intersectionality and interdependence is oh, how weird. It says our breakout room will close. No.
I think it's a mistake.
We are having some technical difficulties. Our team is working to try and extend us. If we do get pulled out of the breakout rooms, we'll be able to rejoin them. So it just might take us a little while. So our sincere apologies for that. Technological stuff.
Yeah, so all of these things are interdependent, and there's also all of the, this is complicated, but I think we start with the complexity and then move down into what is how we can come up with solutions to address this complexity, but acknowledge and be fine with it.
Carolyn, I would add that I think one question I have is whether or not racism itself is acknowledged as a social determinant. So we have, I can tell you, in among health systems, that is a growing trend to call it out.
We're back. Bruce, I think you were in the middle of talking. Yeah. Oh, you're on mute right now.
My question was whether or not we acknowledge and call out racism as a social determinant in and of itself, which I think is something we're seeing increasingly, at least among health systems that we deal with, and that which has led them to some of them to adopt very specific anti-racist policies, even in their organizations, internal operations. If they're academic medical centers, like Ohio State Wexner is probably a leader here in their curricula and other activities that they pursue as academic institutions, and also in their policy positions that they take as an organization and what they advocate for. And so I think that is something that's out there. It's something to discuss. And I think if we were to go down that pathway, then that has potentially, explicit implications for PCORI's agenda going forward. So I just want to throw that out there as a thought.
Can you say just a tiny little bit more in terms of agenda, PCORI's agenda, what your thoughts are?
I actually don't know what it means, but if PCORI's agenda, which I think is sort of what we're thinking about here, that's the initial essential product, is, if we recognize racism as a separate social determinant, the way we do the other factors that Dr. Gee and others mentioned here earlier, then the question would be, does PCORI, in terms of comparative effectiveness, is racism part of that agenda, or racism in healthcare, and the effectiveness of organizations' efforts to combat racism, say within their own organization, which quite a few have taken on. So it's a blue sky thought, perhaps. But not as far out as I would have said 2 years ago, at least from the what I'm seeing out there in terms of where the energy is around perhaps more engaged organizations.
Thank you.
I agree with the. Oh, I'm sorry. Go ahead, Pat.
No. Go ahead, sir.
Okay, I just want to say I agreed with Gwen about a focus on social justice and not just disparities. It's really thinking about where we're trying to move forward in the next 5 to 10 years. And another area that I think should at least be acknowledged that wasn't really discussed is social justice around individuals with physical disabilities, and particularly those that have developmental disabilities who have had a history of discrimination, had to fight through the courts, and many of the issues that were raised related to such things as redlining have applied to those individuals, as well as they've tried to maximize their independent living, and it has had real health consequences for them. Just another area of consideration to kind of broaden out the picture.
Patrick,
So-
I think. Oh,
This is Brian. Hello.
hi.
Since we started out with the focus on the social determinants of health, and again, I appreciate Patrick starting us off this way. We've already boiled 12 social determinants down to 5, and even those 5 probably are not going to be, they're going to still be pretty broad. So I want to think about the work and environment aspect of it. If we're going to think about disparities in health outcomes, we have to think about disparities in access to care, all these other things that we know about. One thing to keep in mind for PCORI and any other group is that in the US, for maybe half of Americans, they access the healthcare system through employment. So to the extent that patterns of employment and patterns of access to not just healthcare in terms of having primary care, but workplace wellness programs, we have to just grapple with the fact that this is going to follow the same racialized patterns as we just see in American society. So that's one of the things I would like PCORI to think about, which is in this private system of healthcare, in this system of private employment insurance, how does this impact people's people's access to care, and how this plays out over the long term. So when IBI, a company like IBI deals with employers, they're thinking about how are we going to manage a public health crisis, but only for our employees and their dependents, and only through our benefit system and the workplace programs, not thinking about the next generation they have to hire. So that's one of the things I would really like to see more brought to the table, which is really just this broader view of how this all plays out over the long term.
Thank you all for those thoughts. So in thinking about social and environmental factors, I think we've already started kind of talking about some of these things, but what do you see as the potential opportunities that come from thinking about these social and environmental factors, including racism, including the way we structure healthcare and access to it, as you've highlighted, Brian, and including all the factors, Patrick, that you highlighted. What are the opportunities there? I want to say, if there's a stronger consideration of those factors as part of of the healthcare enterprise more broadly, and PCORI more specifically, what's the hope? What do we hope to get to? Or why will that matter? I guess
For me, as a PCORI ambassador, you know, PCORI and the National Academy of Medicine has the opportunity to be bridge builders. So, you know, I often use this particular analogy. A lot of times when you get invited to the table, you don't get to control what you're being served. But let's say PCORI, for each individual or organization that applies for a grant for their particular research opportunity, let's say they go with PCORI out to the woods. They pick a tree. They all cut the tree down. And everyone that's going to participate in this project will build that table, that particular table. So where they're able to sit down at that table, so they have ownership at that table. They can have a place setting that makes them feel comfortable, a chair that makes them feel comfortable. And you sit down at that table and you're free to have, as it was stated before we went into the breakout session, the uncomfortable conversation. We're free to ask the questions that may be on folks' minds, but they never knew how to approach the topic. I believe that would create understanding. I believe that would break down some communication barriers. Maybe it will change some implicit biases in current healthcare policies that are developed that may be barriers to blocking any type of changes. I think with a strategy like that, you're headed in the right direction, and it would just allow folks to be more emboldened to advocate not only for themselves, but, you know, just for equality. And a lot of people fail to realize that even though it may be equitable, it may not be equal. So if you can make everything equal and equitable, I think you're really headed in the right direction.
Caroline, can you restate your question again?
Yeah, I guess I'm trying to think about what what are the different things that we would be doing in the healthcare enterprise if we really embrace thinking and doing work around social and environmental factors.
Yeah, so I would, and I'm sure, running Siren, this will not be news to you, but there is a lot going on around social and environmental factors in at least the healthcare space I'm familiar with. Is it evidence-based? I don't know. A lot of it sounds like good ideas. And I would, whether or not it's effective or more effective than other interventions, say for food insecurity or housing, or even for combating racism, like the implicit bias test is one intervention. I don't know that we always know that. And I think there's a lot of untested things being used or approaches. So I think by embracing this, you legitimize research into this area, and you actually can conduct research into this area to start to inform practitioners about what they should be doing, and more importantly, what they shouldn't be doing. I am very concerned that if healthcare systems, and again, I'm speaking from a hospital perspective, continue down the pathway of trying to address social determinants of health and see no impact 5-10 years out, then they're going to walk away from this work. And that is an issue. So that is just one area or one reason why I think it would be important.
Also offer some insights to both what Patrick and Bruce are saying. And I think it's something that Karen raised as well. We're really looking at this from the healthcare enterprise perspective, and I understand why, but we've got to take a step back in saying that this is something that healthcare solely can address or has the majority stake in addressing when we talk about social and environmental factors. And I think there's a true disconnect or a misalignment of resources across the various sectors that do have an impact in one's overall health and well-being. And I'm somewhat guilty of it in my own program, which is what we're trying to move away from. It is continuing to say, well, what can we do in the healthcare sector? What can we do at the hospital level when it's really so much more than what's happening within just those clinical walls? And we need to figure out, how do we break down those silos? So if I'm thinking blue sky, I don't know what it looks like, but it's hospitals getting out of their own way to be working with all of the resources at a community level to truly address the well-being of the full patient, I'll say patient, but the full person that's stepping into this realm.
I see some alignment there, what Ivory is saying about the healthcare system. I mean, if you just think about the mission of a hospital, day in, day out, everybody who's there to take care of people as they come in, now they go from people to patients in that moment, they're not necessarily thinking about this larger term picture. They can't necessarily. And I'll take it back to how employers think about this as well. They're there to make things and sell things. And they offer healthcare benefits because that's what legitimate companies in the US do. But they're not going to think about it all the time. And they're not necessarily going to be focused on the people they hire and their entire history. You hire a person's entire health history. With what Ivory is saying is the hospital has to deal with everything that has happened to a person up to that point and try to get them to a better place. Employers think about it in the same way. And so because they're not a healthcare system to begin with, they're so focused on trying to do their main business and then trying to manage people's benefits, which means trying to get their arms around this larger public health issue. You can just kind of see this spinning. And I have the same concern as Bruce, that we'll talk about social determinants of health for a few years. And then when things don't really turn around and employers are saying, we don't even have good information on health outcomes among our employees that we've spent all this money on they think of it as their money. We spent all this money on their benefits. We can't tell you that African-American employees are having better outcomes than they were 5 years ago because they don't do the surveillance on it. Well, is there a point with which they're going to wash their hands of this? And that would be a concern of mine. Same as Bruce's concern. where's the evidence? What is the evidence? What would we consider to be evidence? And who's going to develop it in a way that's going to be believable by all these different stakeholders? I have no answer. Sorry.
So I think that so Dr. Poe talked about it, Neil Poe talked about it when we started, which was really thinking about health and healthcare. So what we're looking at is transforming health. And so healthcare is a means to transforming health, but is only one of the means. So one of the things that we talk about a lot, and I chair the patient engagement advisory panel for PCORI, is we talk about what the trade-offs are and where we put our money. And I think that's been brought up, and where we put our funding. That's certainly been brought up throughout all the conversations today and yesterday. But I was thinking about Patrick's comment about early childhood education. So a driver, an incredible transformation in health is by supporting education, is supporting access to food. I mean, there's so many things. So if there's so many things we can do to make a huge impact, but I think Bruce and Brian are very correct in terms of we have to figure out how to measure that. But we have to think about how we're measuring and what kind of evidence we're willing to give value to and say this is good evidence, because this kind of evidence has traditionally been farther down on the kind of hierarchy of what's acceptable than things like clinical research. So we have to look at that. And I know PCORI certainly has a mission for research done differently, but we need to also enact that mission and make sure it goes beyond PCORI. PCORI is a model for other people. But I do think that really focusing on transforming health and not continuing to talk about transforming healthcare will lead us to the place that we want to go.
I agree with that. I think that, it's going to require, this is uncomfortable, to kind of move more upstream, in the process, away from a lot of decision-making the hospitals are doing. Those are very important. Those are still important research areas. But if we really want to address these issues, we're going to have to move more upstream to look at how these social determinant factors do drive some of these results. I mean, I think everyone feels fairly comfortable with the notion that transportation, for example, we pretty good research on the importance of the relationships between transportations and access, which is very important. But I think we have less an understanding about things like, food insecurity and issues related to housing and, other kinds of elements kind of relate to that. And to do that, we may have to look at these research questions from different lenses, because I think if COVID has taught us anything, the relationships between the public and private healthcare system now is much more blurred than it ever was in the past. And that opens up opportunities to begin thinking about different kinds of partnerships that one could put together to be able to answer questions in fairly novel ways. Like, for example, natural experiments as opposed to formal experiments. Those are just examples of things that one could consider to try to get at some of these broader, factors that we're trying to look at in a way that might be approachable from research. Again, assuming the kinds of evidentiary standards that these methods provide are acceptable to decision makers that we would want to act on it.
So one of the things that I'm hearing, and I kind of want to put out there as kind of a very blue sky kind of thing, is building, I think, on what Ivory mentioned, that so many, and what Gwen mentioned. So if the focus is about really thinking about what generates health, and so much of that are factors that are not healthcare. Does this mean, PCORI should really be thinking much more broadly about the kinds of interventions that it should be researching? So should PCORI be expanding its scope to be saying, we should look at the impact of early childhood education investments on health outcomes, on patient-centered health outcomes? We should be looking at how investments in transportation or different transportation approaches, education, anti-redlining, et cetera. Thoughts about that?
Or the built environment.
Yeah.
as a major barrier and discriminatory factor across communities that has really limited opportunities for people to achieve the health that they desire.
So I would also say, so I will just reinforce, so our Patient Advocate Foundation provides direct patient services to 175,000 under-resourced and underinsured people every year with multiple different serious and life-threatening illnesses. And the number one reason people call us is for transportation. Now, there are multiple reasons, so it's not like it's the majority, but the number one reason people call us. But it also is a way of thinking about some of the goals that people have talked about before, like the one that, as a 3-time cancer survivor, I will say the one that makes the hair on the back. There are a few things that make, actually there are many things that make the hair on the back of my neck stand up, but one of them is this notion of being a compliant patient and an adherent patient. And it usually gets down to the individual. We talk about the individual responsibility for that, but what we don't always ask is what is preventing both the patient and their healthcare provider from adhering to the care plan that they jointly created. And there are so many factors in that aren't necessarily brought up. It's usually the framing is the patient, the goal is to get the patient to be adherent, as opposed to looking at the root causes of the lack of ability to follow to adhere to a care plan on both sides, the clinician side and the patient side. So that's sort of one example of the ways that we can look at things a little bit differently.
Yeah, I certainly agree with that. So I would also add to that, communication matters. Particular microaggressions should also be addressed, because that is a trigger word. Folks are quick to say, you're not in compliance, but they never ask what happened. And if you can just remove that judgmental and condemning language from engagement, again, you'll be going in the right direction.
So Carolyn, to your question of what should PCORI be looking at, I mean, they can look at these longer term issues, and Stephen mentioned natural experiments. That's always a great approach, but I think one of the things that you wouldn't want to overlook, and it's perfectly within PCORI's bailiwick, is what are people looking for? What are their own expectations for their own health? What are their own expectations for care? I see we keep drifting the conversation back to care, but what are people actually trying to achieve by having what they consider to be a level of good health? And it could be all kinds of different things, but if that is the kind of evidence we're willing to consider in these longer term assessments of are things going in the right direction, then that's probably where you'd want to start. And unfortunately, by the time you have a nice natural experiment, well, not a nice one, but a horrifying natural experiment like we've seen over the last couple of years, not just the pandemic, but think of Hurricane Katrina, when all those kids getting sent to different school districts around the country, things like that. It's a little bit too late to start asking people, what do you really expect for your own outcomes? What do you expect for your own health? So that may be one of the areas where they might want to concentrate, which is, it's the patient-centered outcomes research is, well, what is really patient-centered and how much is out there and how much can we build upon?
Anybody want to build on that at all? How does, I think there's a question there around how does this idea of social and environmental factors fit in with the notion of patient-centered? I think we've heard a little bit about this in terms of asking people, what are some of the obstacles to you being able to engage in the care plan. Brian is highlighting another way. Does the patient-centered kind of frame how does that fit with the social and environmental factors? Anything else that comes up for people around that?
So I just want, one of my friends who is a sociologist and also a long time caregiver was talking about her experiences as a caregiver for her mother who has multiple chronic diseases. And she said nobody ever asked her mother what she wanted her health for, which I think is a wonderful way of framing a question. What do you want your health for? Because that is more than just what do you want your health outcomes to be, but what is it? What are your life goals around your health? So I've always loved that, and I quote her all the time on that.
It reminds me of Atul Gawande's book on being mortal. Is that the name of the book? I can't remember now the name, but I think he makes a similar point that it is so important to understand what matters for people. And I this is one of the things that I always try to remember. I think in the health field, we always think that health is kind of the end goal, but for most people, health is not the end goal. You don't want to live to be healthy. You want to be healthy to be able to live and to be able to, you know, be with your family and achieve all the other goals. So yeah, thank you for reminding us of that.
And sorry, I'll just add one thing to this, and actually Bruce's organization and my organization were both involved in the dissemination of research around conversations about cost of care. But one of the things that when we've surveyed our patients, because we survey our patients with some regularity, if you ask them what the outcome they feared most was, it wasn't a bad health outcome. It was being financially devastated. It was leaving if they didn't survive, leaving their families in bankruptcy. And that was their fear. Another fear that they had was being readmitted to the hospital. That was a huge fear for people. But I think Caroline, as you said, we don't pay enough attention to what patients and families really fear, what they care about, what we can do to help mitigate those aspects. And we've certainly talked about the health, access to health, and there have been ranges from consumerism, which is another thing that makes the hair on the back of my neck stand up, to single payer. So there's this whole range that we can look at to ensure that people don't have to choose between food and medicine. They don't have to choose between housing and adequate healthcare. I mean, there are just so many trade-offs that people make. So I think we should look at that as well.
So part of what I'm hearing in this is that focusing on what patients and families want their health for, and what are the things that matter to them and what's going on in their lives is one of the ways in which these social and environmental factors are going to become visible, that will pull that in. And in some way for PCORI, that's one of the ways to kind of link this idea of social and environmental factors to a very clear link to the mission. Does that resonate? Or folks want to amend that or add anything?
The only thing I would add, and I think this is, I think this is really important, is that some of these things are a tactic to achieve a goal, and that's a tactic to achieve a goal. That's not a goal in and of itself. It's just like diversity. Diversity is a tactic. And there are things you can't do without diversity. And we heard a lot about the diverse workforce, which is critical, but it is a tactic to achieve a goal. So I think one of the things that happens often in these discussions is that tactics become conflated with goals.
Mm-hmm.
And I think we have to be really clear about which is which.
And the goal, Gwen, in your mind is?
The goal in my mind is health, is transforming health. And just health, not just, not just health, but just health.
From a justice framework. So what will it take? I think the central question for us is kind of what will it take? What do we need to do? What does PCORI need to do for us to have, with the tactic of thinking more and doing different things related to social and environmental factors? What do we have to do to have a measurable positive impact on health and health equity in the next 5 years? What are the things that need to happen?
I wonder if it's the 5-year time frame that's causing people to go silent here.
Do you feel like that's too short?
You know, you're trying to undo decades, if not centuries, of harm. And again, you know, like Dr. Poe said, building on a car with a broken chassis while it's rolling down the highway with no brakes.
Where do we start? No, I totally hear you.
In 5 years.
Yeah, how do we start making a difference? Maybe is another way to frame it.
I think, oh, I'm sorry. I think you have to look at the successes and the failures. Look at what has already been done, and look at the areas of where you see movement and kind of try to build from that. I know a lot of folks don't want to take on the task of literally taking a sledgehammer and knocking the wall down and rebuilding it, but maybe that may be what it would need to be done to kind of get it done the correct and productive way of doing it. Is just trying to think about how much time are folks willing to dedicate to actually do that.
What would you take a sledgehammer to, Patrick? I'm curious.
To everything. I mean, even the definition of racism. Everybody has a different definition of it. The conversation. It's interesting when people of color talk about racism. The first thing that comes up is if you talk about it, that means that you're racist. You know, and it's crazy. You know, especially if it's something that's affecting you personally, and if you talk about your pain, then you are the aggressor. And the aggressor, the real aggressor ends up being the victim. So this is why a lot of people of color are used to these biases. If you look at older folks, a lot of folks don't even know that they're being treated with bias or forms of bigotry because they are so used to it that, you know, if you told a person that they have been discriminated against, sometimes people wouldn't even know, or they may just shrug a shoulder because it's just commonplace in this society. You know, so there's going to have to be re-education for everything. So yeah, if you just took a sledgehammer, I mean, you'll be knocking everything down really, and really taking on the task of trying to rebuild with loving your heart and just being open-minded and objective.
If I could ask a question, and this perhaps displayed by ignorance, but I'm curious, and I expect Gwen and Carolyn have thoughts about this, as well as others. To what degree, when you look at patient-centered outcome research today, and you know, the term patient to me immediately drives you into the healthcare system for better or for worse as a frame of reference. To what degree is that research focused on social determinants from the patient's perspective? Is there a body of knowledge out there around that? Or is that an area that's not really been explored?
I think it's an area relatively new to PCORI, but I do think there is a body of knowledge that is rapidly developing out there. Now, in the context of what PCORI does in terms of intervention studies, because we like to compare options to deal with these kinds of decisional dilemmas. Should I take this path or that path to address what I really am trying to get? There needs to be a little bit more, work there to really understand, how those interventions kind of work in the frame of trying to allow individuals to achieve their desired health states. But it is not, it's something that, that I think PCORI should be looking at and should be engaging in if we're going to have any opportunity to address remotely the kinds of issues we're talking about here. And I think also that, given the notion of a sledgehammer, another way is to create some new open doors. There are individuals in the research and stakeholder community that have been committed to these issues for a long time. Maybe PCORI ought to really make an effort to invite them in to become part of the family. And also have incentives for those organizations that have been committed to providing these types of services, whether they be health or social, depending on the nature of the goals that patients have. That should be, maybe there should be some incentives to kind of broaden that family a little bit, to bring in people who have been committed to these kinds of issues for a lot longer than PCORI has. Yeah, so thank you. So that, so that was sort of where I was headed, but in my ignorance, I didn't want to jump too quickly there. But I'm thinking of what's doable for PCORI in 5 years, and I'm not sure it can overhaul the entire healthcare system or health system, but if it could make some measurable progress in aligning PCOR and research and social determinants of health, and understanding what patients want from work and social determinants of health, and it may be not to be bankrupted, and maybe to have a roof over my head, and how we get there in terms of effective interventions. I think that's something that would be worth PCORI's time as a priority. And it could possibly be both research and it could be training. Take these individuals and train them to make that transition to operationalize these aspirations in patient-centered outcomes research in a way of defining it that works, within our congressional mandate. So it's broader, I think, than just doing research studies.
I think one of the huge opportunities that PCORI has is in the reauthorization language is being able to consider the impact of cost.
Yes.
And that is a huge transition, because you can't do patient-centered outcomes research if you can't think about cost. And I don't mean just cost of care, clinical care, it's the cost, opportunity cost, life cost, all of the things that people experience as cost. So I think that's a hugely that has the potential for a huge transformation for the way that PCORI really achieves all of the facets of patient-centered outcomes research. And I think the other thing that I've just noted is Dr. Cook's emphasis on engagement and leading with engagement. And I think that is also an area that she's showing one of the paths forward for PCORI and priorities for PCORI, which is really focusing very strongly on engagement. So Patrick's metaphor of cutting down the tree and everybody making the table who's going to sit down around it, that really gives us the opportunity to do that with that focus on engagement.
I want to just interrupt for a quick second and welcome Nadine Gracia, who's just joined us.
Yeah.
You want to introduce yourself just quickly to the group?
Sure, thank you. Hi, everyone. Nadine Gracia, I'm the Executive Vice President and COO at Trust for America's Health. Great to see good friends and meet new colleagues. Sorry that I'm late. I unfortunately had an unavoidable conflict that arose early this morning, so my apologies, and looking forward to hearing the rest of the discussion and participating.
Welcome, welcome, welcome. We're talking right now about what it would take and what PCORI can be doing to have an impact on health by considering social and environmental factors. And I'm wondering if it would be, I would love to hear kind of if there, and I think we're kind of getting there. Well, let me, before I preempt that, other thoughts that people have about that. What is it that you think needs to be done to get us to just health, as in health that is just, using a strategy that focuses somewhat or incorporates social and environmental factors?
You know, the conversation of the last few minutes is really driving towards this issue of engagement. I'm glad we're not going to overlook that. So IBI generally, my group and me specifically, we're asked to help PCORI understand a stakeholder, i.e. employers, and what does that stakeholder think about? And the approach has been, you know, can you ask them what kind of evidence they value? And I think where there's an opportunity, and it's not been properly exploited yet, is to think not just about their perspective, but trying to show them where their interests align with the interests of other stakeholders. And this goes to Gwen's point about, if you're going to talk about cost, it's not the cost of the healthcare system, it's this larger societal cost of these environmental factors that are producing these different kinds of outcomes in health, and how that flows down to the employer's business, if that's what they actually think about when they think about health. And that's, I think, been the blind spot, is you can take stakeholders, and if you're not really engaging them, you're kind of assuming what they value, and you're kind of assuming what their interests are, and trying to find those alignments kind of in a vacuum. And you still haven't gotten to that point to say, okay, if everybody's interests align, if everybody's better off if people are generally healthy than not healthy, first of all, let's put aside that they have different definitions of health. Eventually, we have to go back to who's going to actually pay the cost in the short term to gain the cost in the long term. Traditionally, that's been the goal of governments, to try and align those things and to take on those costs where the business community won't and the local community can't. And who's going to guide that? So I know PCORI is not a government institution, but there is a larger stakeholder that's missing here in all of this, somebody to organize it. And that's just to get the conversation started. So that may be the place to start, is getting those different kinds of stakeholders to, I guess, put their position on the table that they've built together, following Patrick's metaphor.
Any reactions to that idea that there's a bit, there's a stakeholder that's really missing for PCORI, and that's government?
Well, we do engage, some governments. The National, Association of State Medicaid Medical Directors, for example, kind of have a representation from state programs. But I don't know if, Brian, you're thinking of a kind of a broader engagement, kind of even beyond that. I just want to make sure I understand where you're coming from.
I just wanted to put it out on the table that if everybody is kind of pursuing their own interests in this, if employers are saying, look, I got to offer benefits and I have to be able to afford them, and they have to be something that are reasonably meaningful to my employees, they don't have the luxury to think about the next generation of employees that they're going to hire, who are going to absorb all of the health inequities, all the health disparities over their entire lifetime, which is now reaching back generations. It's too late for employers to solve this. So who's going to be responsible for looking at the big picture to help businesses lower their own costs, achieve a much more benefit from higher productivity, and at the same time have that come not at the expense of the human beings they employ? There's a larger structure for that, and I don't know where it is and what their role is for that. But again, I think a first step, a potential first step, is to kind of get the different stakeholders to put out not just what they want. This, if we're looking from a patient-centered perspective and we're asking, what do you want from health? Ask employers, what do you want from healthy employees? And what do you expect of them? And where can we see things start to line up? So at least you have the opportunity to say, everybody wants the following, these things in common. Who is going to actually end up paying for that? And now we're getting into a different kind of discussion. But that's all I meant, is there has to be a starting point where people are really putting their own perspectives out there, as opposed to, you know, you're going to hear it secondhand from Brian Gifford, who works for IBI, who talks to some employers who are advised by benefits consultants. You know, am I really, is that really going to carry forward? I don't know. It's a start.
So what, I'm curious, kind of, let's say that you think of yourself as being part of PCORI's governing board or leadership, and you've got to pick some actions to take as a place to start to respond to the increasing awareness of the importance of social environmental factors, of things like racism, both interpersonal and structural. What do you do?
You turn to Dr. Cook and say, give me an action plan for this in 90 days.
Now you're Dr. Cook. What do you do?
I turn to Steve and I say, Steve, give me an action plan for this in 75 days.
Thank you very much.
I guess my, you know, and I don't, you know, hang around PCORI enough, but I would say, given, here's the 4 things that PCORI does around education, you know, convening, establishing the evidence, and it has to be patient-centered. I would say, you know, in each of these areas, tell me the top 1 thing we should be doing. I mean, I don't think PCORI can take on 50 things at once in a new area. I don't think it should. And it certainly has a broader other things it has to worry about. But I would ask for, you know, what's the top thing in each area I should be doing? That's just one approach.
And I like that approach, Bruce. And I would say, and then within each of those, asking the question, who and which communities are disproportionately impacted, who's not at the table, so that we're not, to piggybacking on what was discussed yesterday, this notion of just let's just keep doing the same thing, but we're trying it differently, but actually completely thinking about different structures and systems and ways to transform. And that may lead to, I think, new partnerships and new ways to have an enhanced and more inclusive engagement, rather than thinking that we can use the same model that has been used previously.
And I'll build on that a little. I think this is building on that, and I'm not as close to PCORI as I could be, so my comments may be a little bit out of context. But the way HERO views social determinants of health, and we also have employers as our main constituents, and helping employers to create cultures of health and health, systems of health for a healthy workforce, including how they can impact the factors outside of the brick and mortar workplace walls within the communities, and who the partners are. And so we talk a lot about about healthcare systems being one of the anchor institutions in a community that can be strong partner for a public-private partnership. We talk a lot about public-private partnerships. So most health happens outside of healthcare systems. And so if PCORI were to continue with along the equipping healthcare systems for better outcomes for their patients, then maybe it's along the lines of equipping healthcare systems to understand the strengths that other partners in the community can help to come alongside in those public-private partnerships for creating just health for everyone in the community, and therefore being able to keep the healthy people, more healthy people out of the system, and being able to focus on the critically unhealthy people who are coming to the system. Some disparate thoughts, but that's sort of how HERO views that. And so measurement is always the big thing in these public-private partnerships. There's momentum growing around the actions that employers can take to support employees who are experiencing food insecurity or financial instability or transportation issues or housing issues. And so the momentum is growing for it to continue, being able to give solid measures for measuring those impact and how it's directly impacting the health of the community and also the health of their individual employees. That would be a significant driver to continue those efforts forward.
And I would also start to think about how do you make those, if public-private partnerships are going to be one tactic, how do you make them durable? I think that's a question that probably needs to be answered here as well, because maybe Karen has seen this. I know I've seen it since I've been at IBI. Is you might have a company that is heavily engaged in the community supporting public health initiatives. And when a champion in that company moves on to the next company, or when the company sees a setback, like in 2008, then the momentum to continue those practices, well, we just can't afford it, or we have other priorities right now. So again, trying to think about different kinds of stakeholders and trying to think about some kind of organizing framework that still aligns the larger interests. And if it's just going to be the goodwill of a single large employer in an area, or I'm out here in San Francisco as well, a collection of employers who are thinking about primarily their own employees, how are we going to make this work and be durable? And again, I think it goes back to trying to first figure out what people are looking to gain from these kinds of partnerships.
And Brian, your point, I think, and Karen's as well, is I think, one of the things that I think we're circling around and is really challenging when we talk about social and environmental factors is that it's not just the healthcare, right? It's not just something that's internal to the healthcare system. On the contrary, it's about how, as I think you said, Karen, health mostly happens outside of the walls of clinical spaces. And it's the collective responsibility of all of our institutions and to help in some ways generate health and well-being. So we keep, I think, going back and forth between that. This is an area where it is particularly important for the think about healthcare as being in terms of its relationship to other institutions and being in partnership with other organizations. I think, Ivory, you brought this up too. This isn't just the relationship of this can't just be the responsibility of the healthcare sector. But there's this need to think about both what can the healthcare sector do internally, and then how does it partner effectively with other organizations and institutions. It's big and it's hard, but it's important. I mean, this is why it's yeah. Nadine, what were you going to say?
I was gonna, and you all may have talked about this in the first hour, but something that we spend a lot of time focusing on it as well at Trust for America's Health is also making that distinction between, for example, addressing social needs versus addressing the broader social determinants of health, and understanding how you're addressing social need that can be at a very individual level for patients that are being cared for in the healthcare delivery system, and that's a critical role and way in which healthcare delivery systems, health institutions are helping to address inequities that we may see, but then also how do we think about the broader conditions? And when we hear talking about social and economic factors, we're really thinking about those in the larger, broader conditions, which agreed, even in addressing the social needs, but in addressing the social determinants really requires that multi-sector collaboration. Part of the challenge too can be the under-resourcing of the other sectors to be able to meet that overwhelming need. And so when we think about it from the public health sector, for example, which we're confronted with on a day-to-day basis now, as we're seeing it within the context of the COVID-19 pandemic, is the chronic underfunding of public health to be able to address many of these issues, but thinking about other areas such as social services and transportation, education, et cetera, food security, where the role of the healthcare sector, agreed, it's not that that sector alone can be addressing these broader social and economic factors, but how it can partner and also be a champion and an advocate for those other sectors to be able to address those issues, I think is critical to not only addressing them, but also the sustainability of those efforts. So we do spend quite a bit of time of really, especially in meeting with legislators and talking about what we mean by the distinction of addressing an individual social need and going beyond to then the broader social determinants at the population level.
Yeah, so what my organization does is really very much social needs navigation. I mean, and the team that I lead actually works at the intersection of the individual, the community, and then system change. And, you cannot change a system unless you understand what's happening in individuals, families, and communities. And you also can't help individuals and families and communities unless you can change the system. So I think one of the real challenges here is to be able to do all these things at the same time and to work on multiple tracks. So on the one hand, looking for models that work and trying to replicate them. One of the a pediatric oncologist, Kira Bana, at, I think she's at the Children's Hospital of Boston, did a project where she looked at addressing and meeting her patients' social needs, and they were primarily about food insecurity and how that impacted the health outcomes. And it, no surprise, impacted the health outcomes very much. But she was able to do a research project that showed that. So Bruce was asking earlier about how do we create evidence. I think we both create evidence and then also elevate the importance of certain kinds of evidence, which is evidence that that we learn from the community and evidence that we learn from patient-reported outcomes or anything like that. And we look at measurement, that so it's not just measurement to help reimbursement or help, they're kind of hospitality measures. Most of these, I call them. Did you like how your hospital room looked? Was the chair comfortable? Which is one of my favorite examples because I have experienced this. But the chair being comfortable isn't a hospitality measure. It's also a health outcome measure because after you have surgery, you're supposed to get out of your bed and sit in your chair. So there's just a way of looking at things a little bit differently. And then there's also a way of doing things differently. And so the challenge is, how do we do all of these things together and keep we talked about learning health system, not learning healthcare system, but how do we really enact that? How do we embody that? And how do we make sure that we continue to make that a core value of everything that is being done, is that what we learn, we use. And what we learn, we use to the benefit of health and people and community. So it's, I think it's difficult to come up. There's certainly no one way to do this. I think part of it is being comfortable, as those of us who are cancer survivors learn how to be comfortable with uncertainty. I think that it's to be comfortable with continuing to learn and understanding that things change, identities change, priorities change as we learn more and more, and we have to be open to that and build that into what we're doing over the next 5 years, not just, and make that very explicit.
So I feel like we've covered a lot of ground in this conversation. And I think we're gonna, at 12:45 East Coast, I think we're gonna be reconvening to do kind of hear from the other groups. So I'm wondering if we wanna kind of shift to just kind of last thoughts, and then maybe we can take and summarizing we do need to summarize kind of what do we think our key points are from this group that we want to share back out. Any final thoughts that people feel like we haven't touched on yet before we kind of summarize what we've got? Feels like people have managed to, this is great. It means we had enough time for everybody to kind of get their thoughts out. Anna, do you want to kind of read through some of the things that you feel like you've identified? Do you want me to throw out some of the things that I feel like I've heard? How do you want us to summarize this?
Sure. I think if you all could start by sharing what stood out to you, thinking about those 4 key questions that we're working through. I'm happy to share my screen and start displaying slides that would sort of summarize some of those key points.
Sure. Why don't I throw out a few of the things that I feel like stood out to me as I was listening, and then we'll let everybody else kind of fill in what I've missed. I think starting from the top, one of the things that I feel like was strong point expressed is that thinking about social and environmental factors is extremely strongly linked to health equity and this idea of just health, which Gwen, that is a term you throw out, I'm interpreting to be about this idea of health justice, of people having an equal, equitable opportunity to thrive and to be healthy and well. And the social environmental factors are, because they influence health so much, are key to that. I think I heard a point about I definitely heard, we heard this idea that these are not things that are unique to the healthcare, solely the healthcare sector's responsibility. They clearly aren't. There are things that the healthcare sector can be doing internally, and then there are, this is an area where the healthcare sector also needs to partner very strongly, and where there needs to be this other infrastructure. Brian, you mentioned, this is a role that government often plays, of thinking about how do we achieve collective goals that are not the sole responsibility of any individual or entity or sector. And this is clearly one of those areas. I heard a point that Bruce highlighted around evidence and a concern that there's a lot of excitement around social determinants of health right now, but a worry that without the evidence of the impacts of these interventions, that they may not be, so people may be investing in interventions that aren't effective, that may lead folks to feel like, working on social and environmental factors doesn't matter. And that there's a really important role for evidence here. And then throughout all of this was the piece around the patient perspective, that ultimately this is about, this matters because, and this matters to PCORI because there's no patient-centeredness without thinking, nobody's life is compartmentalized into, okay, my health here and my economic worries over there. It's all integrated. And so being patient-centered means you have to be seeing the whole life of individuals and thinking about how all these factors matter to people. And that's kind of one of the, the evidence and the patient-centeredness feels like it's one of these are the entry points, the key ways in which this intersects with PCORI's work. Okay, those are some of the things that stuck in my brain. What else the folk is important to kind of share out with the rest of the group?
I agree with everything that you just brought up. I've received that. I also want to kind of highlight who we may not have talked about, or if it was spoken, maybe I missed it. It's the support system or the care partner and caregiver. A lot of times in the patient community, especially when you're living with a chronic disease or chronic or terminal, a lot of times patients will be abandoned. I've seen, you know, I'm living with chronic kidney disease, and I don't know how many marriages that I've seen broken because they can't live with somebody that's on dialysis, or they can't live with somebody battling kidney cancer, or, you know, anything like that. But for those that are fortunate enough to have a support system, sometimes we leave them out. We don't take into consideration the burden on that particular support system that's very impactful to health and their health as well. We don't talk about, and I know it may be inclusive, but the mental and emotional well-being of these folks. And sometimes these are your best advocates, because they can help the providers to be able to convey whatever message that the patient may not be able to articulate. So I just wanted to throw them in there, but I agree with everything that you said.
Thank you for sharing that. Yeah.
Let me go ahead and share my screen. I've been taking notes during all of this, and I've been attempting as we go to pull out the points that were really standing out to me. So thinking about the questions that the group was specifically asked to consider, thinking about the additional topics, I'm displaying on the screen here.
Oh, we can't see your screen, Anna.
Oh, sorry. Okay, there we go. Is that working?
Yep.
We've been a presentation mode, so it's just a little bit bigger. Okay.
We're seeing, just so you know, the version with the notes right now. Doesn't matter though. Keep going.
There are no notes, so let me.
Yeah. Keep going. Keep going. I think we're going to run out of time otherwise.
There we go. Thinking about the big picture here, that the importance of linkages between different social environmental factors to different sectors, and really emphasizing the patient-centeredness. Thinking about the second question about potential challenges, disruptors, or opportunities. The concern about evidence shows up in two places. I have it listed here, as well as the issue about the durability of the cross-sectoral interest. For the third group, really diving into this need to develop a strong evidence basis to support the concern that if we don't have this evidence, it would prevent progress. And then, Gwen, I think your point about the goals and tactics falls into a potential obstacle here if we're not clear about what the goal is. And then thinking about what else will it take, I think this idea of collaboration and the impact of cost is what was standing out to me. So if that sounds okay to everyone, I think we're actually being called to go back into the main group.
I think that you've managed to capture a lot of what we talked about. And thank you so much for doing that. I want to thank all of you for sharing your thoughts and being part of this process. It's really been enjoyable to get to hear all of your thoughts and get to know you a little bit better through this process. It's exciting to know that there's others.
Thank you for your facilitation.
Yeah, thank you.
Great.
Thank you.
Thank you so much.
Thank you all.
See you all in the big room.
Okay. Bye.
Thank-
Bye.